everybody, thanks for joining me today to do some menopause case studies. I know you had a great lecture with Colleen Gardner, and she's definitely an expert women's health provider. I have went ahead and dug around to find a reference article that had some current dosing for all these wonderful menopause medications, and let me show that to you now before we proceed with the case study. Okay, and this is the article that I found that went with a little deeper dive and some of the details on the various therapies for menopausal issues. It's entitled Pharmacological Therapies in Women's Health. The first part of this article is focused on contraception, and the second part is on menopause treatment, so we'll just be using the second part. All right, and if you'll go to page 778, which I believe is page 16, just viewing this document online, you'll see right here the menopause section begins. And, of course, we're going to have a bunch of menopausal women come 2025 is the first thing that jumps out at me. I think mostly we're going to be using the reference tables here. The first couple boxes, box 8 and 9, we really don't need these. I think you're pretty familiar with the definitions of menopause, but there they are if you need them. And the common symptoms of menopause and postmenopause. But we'll get down to here, the table 5. You'll see that there's some dosing on the bioavailability of the estrogens used. And then table 6 is really great because, again, it gives you some details that I don't think you got in your lecture on the products that are actually prescribed. Some, as you can see, are available in generic, like the estrace. Other ones that are brand name only. Some come in multiple doses, and others just in a single dose, like the vaginal ring, obviously. So table 6 we're going to use in our study, and there is a box of clinical pearls. So lots of great advice in this table. I hope you'll review in regards with the prescribing. I think the biggest one is towards the bottom here. This, you can choose to start with a standard dose versus a low dose and titrate symptoms to control. So that's, I think, the important takeaways. This is something we're going to titrate up. Maybe after some time in practice, you'll have a sense that maybe a lower dose won't work, perhaps, if somebody's in the throes of menopause. But I think, in general, that is it's start low and titrate up. And then monitoring of estrogen levels is discussed here, along with some of the issues with the combined products. And then going on, let's see, the next table is definitely some of the non-hormonal treatments that you might consider offering your patients, and the typical dosing of these agents. SSRIs being real commonly used, clonidine, gabapentin, all kind of non-hormonal options. We definitely have women who aren't able to take hormones for various reasons. And then some of the genitourinary symptoms of menopause. Some of them, again, topical hormones, vaginal rings, and then a lot of just vaginal moisturizers and lubricants that might be helpful to women facing these issues. And then this box 11 is also really great, of when do you stop. So also reference this in the case study. So that's the end of the support documents that I'd like for you to use as we go through these case studies. Thank you. Okay, and without further ado, let's start our case study of a 51-year-old woman that complains of fatigue, irregular menses, and night sweats. Okay, and here we get some more details on the case. Our patient's name is Barbara, and she comes to the Women's Health Center with a history of night sweats, irregular menstrual bleeding, fatigue, labile motions for the past 6 months. She is married and she works in the emergency department as a registered nurse. All right, so let's not jump to any conclusions, even though this is a case study on menopause, right? What's your differential here? There's actually, I'll say there's 7 things to consider this could be, besides, what we're thinking. So go ahead and list out your differential. Also, if you don't mind, if you'll include your rationale for each of these differentials you're listing. You don't have to list all 7, but try to name at least 3. All right, great. Thanks for your feedback. So now let's go over some of the things you might have thought of. The first thing that comes to mind is this could be hyperthyroidism. Often folks with hyperthyroidism have hot flashes and irregular menstrual bleeding, so this is definitely at the top of the list. I think I told you guys when I did the thyroid lecture that my mom, when she had her thyroid condition, she was misdiagnosed with menopause because she was kind of that age, getting up in her late 40s, and her physician, who was a really wonderful guy, I knew him from working with him for a number of years, he just told her she had menopause, but then she looked in the ladies' home journal and went back and said, I think this might be my thyroid. And sure enough, it was. And she got the radioactive iodine treatment. What's next on the list? Anemia. The rationale for that would be that she is complaining of fatigue, and she's experiencing irregular bleeding during her menstrual cycle. Next on the list, a viral infection certainly could give you some, vague symptoms. HIV and hepatitis, or more serious viruses, and night sweats could be a sign of HIV with a primary infection. So if this woman was working in a high-risk environment for HIV exposure, that should definitely be a consideration. And she is, working as a nurse, so that is something to think about. Did she have a needle stick within the last, few weeks? All right, and next on the list would be depression. The rationale for that is that Barbara complains of having labile emotions, which can be a sign of depression. Sleep issues can, lead up to depression. And then, working those, the shift work like ED nurses usually do can be very demanding, both physically and emotionally. Next, other infectious diseases may be the cause, not the viral kind, but the tuberculosis is known to cause night sweats, and also malignancy can cause these symptoms of fatigue and night sweats as well. So it's something to consider. You'd probably rule out, the menopause first, maybe, but it'd definitely be something to have on the list. People at high risk for tuberculosis, foreign-born individuals are at high risk. Those with HIV, of course, would be higher risk for having a case of tuberculosis as well. Next on the list is menopause, which that's what we're all thinking it's going to be, right? And with that, of course, we have night sweats, the labile emotions, irregular heavy periods are all part of menopause. And then last, the endometrial cancer. This is the kind of cancer that is known for causing irregular bleeding and, in advanced stages of the night sweats and fatigue as well. Okay, and here we finally get the full HPI, a little more detail than the chief complaint for Barbara. She complains of fatigue for actually 6 months, along with shortening of the intervals between her menstrual cycles. She reports her cycles are heavy one month and then light the next month. She's waking up 4 to 5 nights a week, drenched in sweat. Her husband is complaining that she's moody and irritable. And she really can't determine when the cycle will begin, which disrupts day-to-day events. This is something that is really problematic for her. And this sweating episodes at night is leading to her having poor sleep quality and even sleep deprivation. Her work schedule probably doesn't help either at the ED, right? All right, now what further history questions do you have? You have the HPI, that's pretty focused. What seems relevant to find out more about? Go ahead and let me know what else we're missing that you really want to know. All right, and here's some little tidbits of history. With the OBGYN history, we have some more details that her last normal menstrual period was 6 months ago. We knew that, didn't we? Light to heavy flow, and a history of shortened intervals between cycles. And then we get some more details here. The 15 to 18 days is the cycle length for the past 6 months. So she had what seemed like a normal period 6 months ago. Now she's having these little shorter cycles lasting no more than 18 days before she starts bleeding again. When was her last pelvic exam? That's a great question. Her last pelvic exam was 1 year ago. She's had normal pap smears for the past 10 years, and we know that's not an annual thing anymore if things are okay. But the ones she's had over that 10-year course have been normal. She did have a previous abnormal pap prior to the last 10 years that had appropriate follow-up with no sequelae. And you probably want to know if she'd had a mammogram, and she is getting one every 2 years over the past 10 years. And here's she's gravida 1, para 1, abortion 0, 1 living child. And then what about that sexual history? We can't assume that people in their 50s are all married and settled down. In this case, Barbara says she's never had a sexually transmitted infection. She reports having 5 partners over the last 10 years when she was divorced 10 years ago from her first husband with only occasional use of condoms. So we definitely have to think about STIs, don't we? She is monogamous with her husband of 2 years. And hopefully at a previous visit she was screened for some STDs given the history, but we can't assume, we've got to check. And then sexual intercourse, she has sex about twice a week with her new husband, and they're both mutually satisfied, and but she reports having decrease in desire for intimacy with all that's going on and her lack of sleep. Okay, and here's other bits of history that you need to know. Barbara's not allergic to anything. She is just taking over-the-counter medication on occasion when she has a cold or a headache. She uses Motrin or Tylenol. With her past medical history and hospitalizations, she had a tonsillectomy when she was young and a spontaneous vaginal delivery in 1980. She was involved in a car accident in 1983 where she did have some internal bleeding and had to have a femur fracture treated, along with she did get a blood transfusion. So that's definitely something to think about, again, with risk for infections that are bloodborne. And then her appetite, she reports, has been fine, along with no recent weight changes. Social history, She's not a smoker. She does drink 1 to 2 glasses of wine per week. Her caffeine intake is 2 to 3 cups of coffee per day, and also 2 to 3 soft drinks a day. If she lives in Atlanta, it's probably Coke, right? No drug use, no prescription medications. She said, I've been married 2 years to her second husband, who's a retired physician, and she has a 30-year-old son from her first marriage. And then exercise, she is finding time to exercise 2 to 3 days per week. She likes to swim, and there's no significant thing going on with her family situation. All right, moving on, we do have some physical exam findings. First and foremost, some vital signs. I say some, not all, because it's not comprehensive, but the blood pressure is 126/80. What do you think about that blood pressure? Is that optimal blood pressure, or is it elevated? And what about her weight? We have a weight of 156 and a height of 5'4". Would you like to calculate a BMI for that height and weight, since one's not provided? Okay, great. Okay, so I got a BMI of 26.8. Is that what you got? All right, and what does that mean? Is this a normal weight? Is she overweight or obese? Yes, 26.8 is a overweight BMI. You know, there's all these online BMI calculators, and you can kind of mess around with them and plug in, you know, different ways to see when it drops down to the being a normal weight. And for her, it looks like a weight below 146 would get her in the normal weight for height range. So, so she really just needs to lose just about 10 pounds to be back at normal weight, and I certainly would include that in my assessment, even though I guess it'd probably be a minor issue compared to everything else going on for her. If she could lose 10 pounds, that would reduce her health risk for elevated blood pressures and other complications from the extra weight. All right, now with her, just the kind of the standard physical exam, you know, there's no abnormal findings. But when we get to the female exam, on the pelvic exam portion, we are given some more details of some abnormalities. There does appear to be a thinning of the labial tissue and vaginal rugae. But the cervix looks pink. There's no abnormal discharge noted. No cervical motion tenderness, and no masses palpated. So that's reassuring as far as any STDs go, or you know, the fibroid tumors. A lot of times you can feel those as well. So there's this pretty reassuring, but we do have some clues of this thinning labial tissue, which you might expect at this age, especially if the hormones are dipping down in the you know, heading towards menopause. Okay, and here's a picture I found for you to peek at of some vaginal atrophy. In this image, it's somebody who's been 2 years since their natural menopause occurred. You can see there is a loss of the plumpness of the labia and vulvar area, which is, you know, fuller and plumper in younger menstruating women. There's a pallor of the urethral and vaginal epithelium, narrowing of the introitus. Things just seem kind of dry. There's minimal vaginal moisture and a loss of urethral meatal turgor. So there's sometimes a picture's worth 1,000 words, and there it is. Something to keep in mind on your exams.